wasn't a bigger need for setting up an office for MacArthur Foundation in India in 1994, just before the ICPD conference. And ICPD happened at the same time, which broadened the women's reproductive health field into a rights-based approach. It should be reproductive health, sexual health, and women's maternal and other health-related issues should be included. So the timing was perfect.
We were the very first batch of fellows, that was 1995. Through our community-based research, through the kind of outreach that we were doing in the area, we got to know that there were so many other issues of sexual rights, of reproductive rights. Hardly anybody was talking about it way back in '95.
The MacArthur Fellowship actually gave me a great opportunity to work with self-help groups of women, where I intended to demonstrate that when women are organized in collectives, they are better placed to demand their rights.
My journey into the field of public health started through the MacArthur Fellowship. I was able to set up an intervention in an area of Rajasthan, through that intervention we were able to set up a clinic in a rural area and some community-based interventions that provided me a deep insight into what are the social determinants of their reproductive health, and that was really a very enriching experience for me.
This whole journey of networking, of capacity building, of having the freedom to do the kind of community-based research that really interested us, that we were really passionate about, that was extremely helpful in terms of shaping our own pathway.
There was a missing link between child and maternal health, and we very soon identified the adolescent age group as the missing link. Three aspects of the work happened. That was to bring in the sexuality education, child marriage, and youth-friendly health services together in the district for all three to move.
So the approach that we took was of, at that time, peer education, but really sort of creating young people's leadership to be able to talk to other young people in a language and about issues and realities that are really of their own lives. So the impact of a program that focuses on, gender sexuality issues went on young people being able to be more confident and active advocates with their own parents around their aspirations, more confident advocates in their communities around access for information to young people. This conversation is now being had in government offices. This conversation is now being had in a whole bigger, wider NGO community where we see ourselves as continuously pushing for young people to be sort of, leaders of that conversation.
When MacArthur came into this space of sexual reproductive health, there were hardly any institutions in that space. So I think they brought this space of adolescent reproductive sexual right within the national dialogue. They strengthened institutions like us to bring this into policy space. It's a big battle. I think we'll have to continue to work. We need to see adolescent in more totality rather than as only a sexual reproductive health identity.
In 1999 was when the National Family Health Survey data came out. The maternal mortality rate was 547. It was quite shocking. Through the efforts of many organizations, including the White Ribbon Alliance, including foundations like MacArthur Foundation, I think people successfully brought it to the top of the table. In 2004 and 5 of the National Rural Health Mission being launched.
The government itself has invested a substantial amount of resources. We did a whole lot of things around it, from transport and ambulances, from giving women cash entitlements so that they could safely deliver in institutions, from creating the human resources workforce around it, from ensuring that there were doctors and nurses from making sure that at the peripheral levels there were skilled birth attendants, and so a whole set of activities designed to reduce maternal mortality.
Post the launch of National Rural Health Mission, you see a lot of women moving to the hospitals. So there was one obstacle crossed. After women started coming to hospitals, the demand had grown so much that the supply side was not being able to cope up. And that's when all of us started working around quality of care.
Earth has provided a lot of technical support in areas of maternal health, safe abortion as well as contraception. So Earth has provided training of trainers for all the 33 districts of Rajasthan in stillbirth attendants.
We started working around social accountability. We organized public hearings. The government mandated maternal death audits. So a lot of multiple partners came into the field doing multiple things.
We also did an enormous amount of documentation on maternal health. The innovative aspect was that it was not done by researchers. It was actually done by poorest women in community groups. All of this documentation was periodically fed back to local providers, district health managers, and definitely to policy actors.
However, even today, 2019, India's maternal mortality is 130, which means that we still have a long way to go.
Quality of care is a persistent concern, and I think we need to be looking at how we have to change the design of certain elements to make quality of care a reality. I think the second big challenge is persistent inequities. So as long as we have inequity in the system, maternal health for the vulnerable will continue to remain a dream. We have to begin looking at maternal health through an equity lens.
The MacArthur program has entirely built the field of reproductive health and rights, sexual health and rights in the country.
Putting women's health broadly on the agenda within the population issues, and that expansion has created a field of its own.